Good afternoon, and welcome to our 2022 UI Health Distinguished Scholar Series. The Office of the Vice Chancellor for Health Affairs is pleased to present this collaboration among Population Health Sciences, the Chief Medical Officer, Chief Clinical Officer, Chief Nursing Officer, Chief Quality Officer, and Chief Diversity and Community Health Equity Officer. This series is intended to offer an opportunity to learn from and share with nationally recognized healthcare leaders. I'd like to offer a very special welcome to our distinguished guest, President of the University of Texas at Tyler, and Chairman of the Board at UT Health East Texas, Dr. Kirk Calhoun. Thank you for taking time out of your extraordinarily busy schedule to share your experience and expertise with us today, Kirk. We've been looking forward to this for quite some time. It's been very exciting to see this seminar series come to fruition. Several years ago, I approached Dr. Christian and others with the idea to engage healthcare thought leaders from across the nation in meaningful conversations so that we may share expertise with our local community to better serve our patients. We wanted to get rid of traditional slide presentations and host more intimate conversations with notable experts that can inform our operations and healthcare delivery. Today's conversation is an exceptional opportunity to engage with a national leader from a peer academic health enterprise. Indeed, we're certain to learn and gain deeper insights into this work through the experiences of Dr. Calhoun. So it's with great pleasure that we welcome our UI Health Distinguished Scholar, Dr. Calhoun, for this virtual fireside chat. Before we begin our conversation, it's my pleasure to welcome back Dr. Jerry Christian for some general introductions for today's speaker. Dr. Christian.
Great. Thank you so much, Dr. Barish, and thank you, all the guests on the panel today, as well as all of you joining virtually for this session. It's my distinguished pleasure to welcome Dr. Calhoun, who earned a Bachelor of Science degree in biology from the University of Illinois Chicago. So he's an alum. He's one of us. He then went on to obtain a medical degree from the University of Kansas School of Medicine, completed his residency in internal medicine at Northwestern, then a fellowship in clinical nephrology, hypertension, and metabolism at the University of Chicago. Following a very successful career in private practice, Dr. Calhoun aggressively pursued his passion in academic medicine, and after several academic leadership positions at the University of Missouri, Kansas City, he then served 10 years at the University of Texas Medical Branch in Galveston, also known as UTMB, as an associate professor of medicine and corporate medical director of the UTMB healthcare systems. He then became simultaneously the senior vice president at Parkland Hospital and the associate dean for clinical affairs at UT Southwestern Medical School. From 2002 to 2020, Dr. Calhoun served as the president of University of Texas Health Sciences Center at Tyler, during which time the campus grew significantly and became an accredited academic institution. In 2020, he was then selected as the president of the newly consolidated UT Tyler, which merged the academic and health sciences center campuses in Tyler, where he's now professor of medicine. President Calhoun is chair of the American Association of Medical Colleges Board of Directors. He's on the executive committee and the immediate past chair of the AAMC Council of Teaching Hospitals. He's the only individual to serve 2 terms as chairman of America's Essential Hospitals, formerly known as the National Association of Public Hospitals. He's also served 2 terms as the DSHS Council, the Texas State Board of Health, and he currently serves as the executive committee of the Teaching Hospitals of Texas. Dr. Calhoun is chairman of the board of the UT Health East Texas Health System, which was acquired in March of 2018. This newly formed health system owns and operates 10 hospitals, over 50 clinics, emergency transport services, a home health agency, and other related healthcare components. UT System Board of Regents recently approved the new UT Tyler School of Medicine, a recognition of Dr. Calhoun's healthcare vision for East Texas. He has served and received numerous awards for his work in healthcare, public health, higher education delivery, community service, including the prestigious Dr. Luke Society, where he was inducted in 2021. He and his wife, Jeanette, were awarded the TB Butler Citizens of the Year Award in 2021, honoring both their contributions and their achievement for the city of Tyler, Texas. So you can see that Dr. Calhoun is one of us and has come back to share with us what all he's learned, and we look forward to a vigorous and informative conversation today. So I get the honor of asking the first question, but as you'll see, other panelists will then join me as well. So the first question I have for you, Dr. Tyler, is when did you know you wanted to be a leader? And was there someone who inspired you to consider a leadership position?
Well, thank you, Jerry, for that introduction. It was very gracious, and sometimes when you live long enough, you get to do a lot of different things. And so I've certainly had those opportunities during my career. And of course, I want to thank my good friend, Bob Barish, who I've known for a number of years now, and I'm so happy that he's there at Illinois, and I know the wonderful job that he's doing in leading that group. It's an interesting question you asked, because, I don't know, for me, it was never as if I thought about being a leader. I knew I liked to manage things. Probably if you found me in kindergarten or first grade and the teacher would say, who wants to put the toys away? I would jump up, I will, that kind of thing. And, I enjoyed organizing it in a fashion that I felt was correct. And so I've always been very open to working with others, stepping up when opportunity presented itself. And as those opportunities did present themselves, of course, leadership opportunities come along. And if there's anything I tend to tell some of the younger doctors is when they are looking for someone to chair a committee at the hospital, for we physicians, that's how it starts, right? It's not as if they bring you in as CEO day one. You're asked to take on a particular responsibility on a committee, or identify ways that you can be supportive in other ways. And if you can do that, if you can use the power of persuasion to bring other people along, then the leadership role will come about.
Great, thank you so much. I think Dr. Hughes Dillard, I think you have a question.
I do, thank you both. Dr. Calhoun, what inspires you in your daily work? We all have something that motivates us, but what inspires you?
I want to always try to leave each and every day, leave our organization, our university, our hospitals. I want to leave them in a better place. And it would be nice if every day could be an advancement. It doesn't necessarily work that way. Sometimes you have down times. There are times you have to make tough decisions, and people are affected. But try to keep a focus on the long term. Try to be tenacious is a word that I like to use, and not settle, and continue to move the organization forward each and every day. And if I can go home each evening feeling a little bit better about what our team has accomplished, then that's a reward in and of itself. And when you can't go home with that kind of good feeling anymore, then that's telling you that it's time to find something else to garner your attention. But we try to stay focused on doing good things every day and serving our patients, serving our students, serving our community, serving our workforce and faculty. If we can do that and accomplish good things, I'm thrilled.
Dr. Calhoun, I have a follow-up question for you. In the past year, What's the most challenging decision that you've had to make and why?
Well, literally over the last now nearly 2 years, we've been merging our health campus with our general academic campus. And the merger was not necessarily done to identify financial savings. It was done to identify ways that we could better utilize our local resources and better serve our students and community. But we would not be fulfilling our fiduciary responsibility if we didn't try to identify efficiencies, identify savings that could occur as a result of the merger, as a result of bringing the two organizations together, and taking whatever benefits from those efficiencies and applying them to our mission. So there were a few areas that needed to be consolidated with bringing the campus along. And in many cases, we had to identify between the two organizations who would lead that area, or will we bring in someone completely from the outside to lead that area? Would we maintain the same staffing levels if those staffing levels were no longer required? These are decisions that affect individual people, people you know, people you work with. And so those kinds of decisions are often difficult, sometimes difficult to communicate, but absolutely necessary. So I think as we have done consolidation across the two campuses and roles had to change, if jobs were lost, that sort of thing, that's always the most difficult and painful experience anyone in leadership can experience.
Dr. Calhoun, tell us a little bit about your journey to your current role as president of the University of Texas at Tyler, and a little bit about, was it expected or is it expected what you're going through back when you applied and got the position?
Well, that harkens back to the first question about the desire to be a leader. When I never sort of thought of myself as someone who would become president of a university. I always thought and had as my career goal that I would be that, I wanted to be in academics, but I would be that person in the background who made sure the trains ran on time. You know, it's being the manager, it's putting the toys in the right spot in the kindergarten class. And I really felt that that was the role I would follow. There was an executive vice chancellor for health affairs at UTMB when I was there by the name of Jim Aarons, an anesthesiologist. And for years and years and years, he kept the hospital going, he kept the faculty practice going. The president was very much focused on the things presidents think about: long-range strategy, fundraising, major organizational issues. But Jim kept the clinical operation going smoothly. And I thought, well, maybe, you know, that's what I'll do one day. And I left there, went to Parkland to work under Ron Anderson, who was a real hero in terms of running Parkland and taking care of the disadvantaged in Dallas and marginalized in Dallas. And that was really very attractive to me. And so I went there under his leadership and had management responsibilities. When the presidency in Tyler came along for the Health Science Center, I thought it would be an opportunity to learn a little bit, that I would come here and spend a few years, hopefully do some good work, and then move on and do the next thing in my life. And you get somewhere, you become attached to the community, become attached to the people. And you don't take advantage of those opportunities to go elsewhere. You build where you are. And with this merger and with the merger that created the new health system, we now have a
to add questions that you might have for Dr. Calhoun by using the Q&A icon at the bottom of your screen. And please also note that this session is being recorded and will be made available on the Distinguished Scholar Series site sometime later this week or next. So thank you so much. Ronnie, I think you have a question.
Thanks, Jerry. Dr. Calhoun, how has the pandemic changed you?
It's we didn't live through the Spanish flu or some prior pandemics that have occurred around the world. This was ours, this COVID-19 outbreak. And it changed us in a lot of different ways. It impacted certainly on the macro level what it did to our society. I'm a very personable kind of individual. I like meeting with people. I don't mind wearing a mask when I should as a physician, but out meeting people, I didn't like having the mask on. I did what we needed to do for public health, but I really dislike that. And so that's on the macro level. On the personal level, I lost my mother to COVID about 2 years ago. And that had a very dramatic impact on the family because she was a very prominent figure in my life. So COVID, I think, has been tough on all of us. I think all of us, nearly all of us, have had someone they knew or a loved one who succumbed to it, and that made it very personal. And I think all of us were affected by the impact it had on our ability to interact with one another. As we began to come out of COVID, I was a little bit more willing to take, and being in Texas, you can understand us a little bit better. I was a little bit more apt to push opening things up again and getting back into our routine, because I believe that we emotionally needed that. And we tried to do all we could to get as many people vaccinated as possible. We wanted to exercise good and wise judgment. If people were sick, don't come into work, that sort of thing, preach all those different things. But at the same time, we wanted to get our students back. We wanted to resume our events as a university. We wanted to reach out and become part of the community and stay part of the community and stay visible. And so I think for us here in Texas right now, we're in a pretty good place. And I pray that we can stay here and continue to have the kind of open society that we all love.
Thank you, Dr. Calhoun, and I'm sorry for your loss. I'm going to pivot slightly. I have the next question as well. So I'm pivoting slightly back to your leadership in particular. So UT Tyler has multiple colleges and schools. Mm-hmm. What is your leadership style in creating a sense of common purpose amongst all of those different units?
Well, I believe very much in consensus. I believe in team building, and I don't believe that the CEO or the leader or whatever has all the answers. And so I try to make sure that we have an opportunity to hear everyone's opinion. I try to drive consensus. What I do try to insist upon, though, is that we make progress and we move as expeditiously as we can, and demonstrate to our stakeholders that we can accomplish things, that we can get things done. And that can be a challenge in the university environment where there are so many differing opinions. I think my job as president is to be that chief cheerleader, to get everybody together, to get us all on the same page, and then aggressively go after what we've decided we need to accomplish. I'm reading this book by Russell Honoré. You may remember he was the general who went down to New Orleans and said, "Put those guns down." And I really admired that because it demonstrated that you can step in and take really strong action, but no one really accused him of being a dictator or not being able to listen to people and so forth. And he emphasizes that leaders need to be visible, that leaders need to push the edge, that they need to, in some instances, believe that nothing is impossible if you can build the right team around you, if you can build a consensus. And that he very much believes that organization matters, and how you can put things together really matters, because if you put things together properly, you give people the freedom to do their jobs, which I really emphasize a lot. If you can't do your job, then it's my job to get somebody in there who can. But it's not my job to tell you each and every day how you go about doing your job. I need to demonstrate that I have trust in you. You need to have confidence in me as your leader, and you need to believe in the direction that the organization has decided to go. And if all those things can be met, then that's fine. My style is I want to let my deans run their colleges and schools, but within reason. We all have budgetary constraints. We all have an obligation to our students to serve them, to educate them. I want to make sure our students can get a job when they graduate. So, I want them well educated, well trained, well prepared for a future that none of us can predict with certainty. So as long as my deans and other leaders at UT Tyler can accomplish those goals and move us along, I'm happy with them. And my job is to go raise money and do other things to make sure they have the resources they need in order to be successful.
Great. Thank you so much, Dr. Calhoun. There's a follow-up question that I might jump in here from Kevin Wren, who is in the College of Pharmacy in Rockford, in Illinois, and his question is, UT Tyler's pharmacy program is also new within the last 5 to 10 years. In his question, what lessons have been learned from their process, and what ways will your College of Medicine work interprofessionally with these other health sciences colleges? So it really links, I think, to this conversation you just had. This is really about interprofessional collaboration across your colleges. Any lessons learned you might share with us?
Yes. Our pharmacy school has had some challenges, and those challenges were sort of principally driven by the fact that at the time UT Tyler started its pharmacy school, there was not a strong desire across the state of Texas to have more state-supported pharmacy schools. So it was actually conceived and brought together as a private pharmacy school with tuition that would be comparable to what would be paid at a private pharmacy school, as opposed to a state-supported institution. And that was rather unique. It was a great way to get East Texas a pharmacy school, which was very much needed. But it was an expensive process. Since then, Texas has placed an emphasis on health. A number of new medical schools have come along, including our own. And new state-supported pharmacy schools have come along. And so UT Tyler's pharmacy school found itself in a disadvantageous position. And so we hope to go back to the legislature and get that addressed when the legislature convenes this January. If I had to say anything about our pharmacy school that would that I'm taking it, the direction that I would like to see it head into is let's make sure that with all of our schools, whether medical school, pharmacy school, nursing school, that we keep them clinically relevant. You know, we can sometimes get, and we should be focused on research. We can be focused on new and innovative curricula. All of those things I'm very supportive of, but it's very important that our students walk away with the clinical skills they need to be successful currently and successful into the future. Pharmaceutical delivery is changing. I mean, there are robots in pharmacies now. The hospitals need a little bit more out of their pharmacy people. The industry has moved along, and we need to make sure that our pharmacists are prepared for the new world of the future, that they have the clinical experiences, the clinical relevance, so that they can go out and be successful competing and getting a job, that they can provide their employers with the skill sets and services they need, that they have the correct IT background to deal with computers and robots and those issues that invariably come up there, and that they can keep pace with the rapid development of new drugs and new therapies and the evolving scope of practice of pharmacists. So all of those things are sort of clinically relevant. Research plays an important role. Innovative curricula play an important role. But to me, that's meaningless if we don't meet the necessary check marks to make sure that we're teaching the clinical aspects of pharmacy in a relevant and meaningful way.
Great. Thank you so much, Dr. Calhoun. And this really kind of reinforces that as academic health centers, we need to be context aware. And the world continues to evolve, and we need to remain relevant and remain a source of the workforce of the future that'll help the populations that we serve. So thank you for that reminder. I think sometimes we tend to be insular, think about the internal needs, but there is a world out there, and we are.
There is a world out there, and I can tell you where it was driven home out of COVID. Look at our nursing crisis that all of us are trying to deal with now. Our biggest school here at UT Tyler is the School of Nursing. It's a quarter of our student body. Yet, despite the production of nurses that we generate and other higher education institutions in Northeast Texas are able to produce, we are still suffering with a nursing shortage here. And we're going to be building an addition to our nursing school. If we can find the nursing faculty, we'll be expanding our nursing enrollment even further. And we are looking at innovative ways that we can work with our local hospitals, clinics, and other healthcare providers to make sure that we have the clinical opportunities that nurses need. I'll just conclude this by saying that there may have been a little concern when I was named as president of the university that somehow being a physician, that the only thing I cared about or would care about would be the medical school. That's hardly the case. I actually like music an awful lot. And being a physician, and I said this at a nursing meeting, no one appreciates a well-trained nurse as much as a smart physician. And so the nursing school gets a lot of attention. here, along with all the other course offerings that we have here at UT Tyler. And being a physician and having a medical school is great, but we certainly don't want to forget that the University of Texas at Tyler is much larger than just its medical school.
Great. Thank you so much, Dr. Calhoun. Dr. Hughes Dillard, I think you had a question.
I do. First of all, thank you for acknowledging our nurses. I am the chief nursing officer, so I understand the shortages. And so this question was actually submitted by one of our physicians here, Dr. Carissa Tayo. And the question is, with the increase in burnout and healthcare staffing shortages, what can leaders do to help? I mean, we're struggling. You know, what can we do?
The demands of healthcare delivery are certainly pretty immense right now. You know, coming out of COVID, during COVID, it put a tremendous strain on everyone. And so it's not hard to imagine that people need a little rest right now. Some people are going to retire and take a long rest. Others are going to be taking breaks. So I believe, though, that even with the increased work demand, increased hours and so forth, all of that we need to try to assist with. It really does come down to, though, job satisfaction. You know, you can sit in that hospital and you've done it forever. If you really think that you're being appreciated, that you're having an opportunity to really serve your patients, that you're doing good things, that you get the good feedback that you want to get, you're willing to hang in there a little bit longer and do a little bit more. And I think for those of us who are administrators, we get so tied up in our own problems and our own pressures and stresses that we sometimes don't pay enough attention to how little things we can do can really increase job satisfaction. And if you increase job satisfaction, then people will stay with you. Even if they don't necessarily, even if the hospital next door is paying $1 more an hour, if those nurses love the doctors they're working with and the doctors show attention and kindness back to them, they're not going to go for that $1 more. You know, it's going to be a lot more money. They'll go for more money, but it's going to be a lot more money. So I think that we sometimes fail to say thank you enough. We sometimes fail to see what little things we can fix for people that will give them a lot more job satisfaction, and that will build loyalty.
Dr. Calhoun, sort of in the same vein, but maybe switching topics a little bit, but around developing our workforce as we have some of these shortages. There's a question that's from Long Yip, a nurse case manager at University of Chicago Medicine. And this question sort of hits home with me as a physician and the chief quality officer here at UI Health. They ask, how do medical students and young physicians get involved in value-based care, population health, and health administration? And any recommendations for degrees, projects, ways to network for those that are interested in a similar pathway as yourself?
Yeah, I believe that for our learners, and I put medical students and house staff as learners, value-based care, quality improvement, all of those, it's on us to build that into their curricula and into their experiences. I think making sure you know if you're in charge of quality in your health system, then making sure that the residents are on committees, that they're involved with it, they're interacting, they're learning this stuff fairly early on. There's going to be a session later on rural healthcare. I like to remind our folks that being in Northeast Texas, a rural part of the state, many of our graduates are going to go practice in small communities where that primary care physician, that family physician is going to be the quality person in the hospital too, while they're practicing. And so these public health experiences need to be built, in my opinion, built heavily into our curricula. And we're trying to do that with our new medical school. As I said earlier, I think it's important too for my advice to young people in medicine and in healthcare in general is, again, this concept of saying yes when you're presented with opportunities to engage. And I've heard some folks say, you know, well, I'm not going to take that responsibility. I'm not going to be medical director because outside my secretary, there's no one else that will work for me. The nurses don't work for me. The doctors don't work for me. You know, I guess I never thought that way. I always thought that if you were presented with an opportunity to lead, you didn't have to have people necessarily work for you. You had to have people that would listen to you, and it was your responsibility to convince them to do the right thing. You know, if you have to convince them that you're saying happy birthday twice when you wash your hands, then that's what you have to convince them to do. That, you know, coming along and pointing your finger at them and say, you know, we're the hand washing police, and there's a camera watching you every time. It's not the way you're going to get the compliance that you want to have. And so you have to be able to convince people, and having our young people step up, take these roles, even when authority and responsibility may be a little bit vague. Go ahead and take those roles and make of it what you can, and do the very best job you can, and convince people of what the right things are to do. And that's my advice to the young folks, and my advice to the faculty is these concepts of value, these concepts of quality, the public health concepts that people have to know. Let's make sure that we teach them well in the curriculum we build for our medical students and house staff.
Thanks, Dr. Calhoun, and thanks for that hand hygiene plug. I am an infectious disease physician, so I appreciate that.
Yeah, most important thing you can do.
And speaking of infectious disease, I have a question submitted from Dr. Alan Harris, the Vice Chair of Faculty Development and Associate Division Chief of Infectious Disease, and the Department of Medical Hospital Epidemiologist at Rush, so at our neighboring institution. And his question is around undergraduate medical education and graduate medical education. And the educational requirements and the accreditation requirements continue to increase at both of those areas, and they're quite labor intense. It also seems that the graduate medical education is shouldering an increase in curricular requirements, which had been previously or are still part of the undergraduate medical education experience. Given current reimbursement for healthcare services and diminishing external research funding, where is the revenue to support these curricular and accreditation requirements to come from?
Boy, I wish I knew the answer to that question. But let me say a little bit about the regulatory world that we live in. And I certainly hope that we can do more about that to figure out ways around it. But there is a certain reality to the world we live in. And we're gonna have the American Association of Medical Colleges. We're gonna have our meeting in just a couple of days. And one of the things I will say at the meeting is that medical education lies at the nexus of healthcare delivery and higher education delivery. Both are highly complex. Both are highly regulated. And that is not going to change for us. We're going to have to figure out how to do these things. Now, how do we afford doing it? It is going to require that we figure out how to do more with less, working together as teams. I think that you make your own life much more difficult if you build silos, as opposed to figuring out how to work with common purposes across the various lines and that can be drawn up and exist. And I guess I like to try to identify how we can do more things centrally and lessen the burden on many of our colleges and schools. That's not in general the way you do with medical schools. Medical schools want to have their own. We have to have our own this, and we have to have our own that, and we have to have our own other thing. I would urge people to begin to rethink that a little bit. And if you can think about some of the support structures for your health education programs and combine that talent and those structures, I think you can lower the cost of many of these kinds of things. We've actually organized our university into two divisions: the academic side, the general academic side, and we have a health side. Health side's run by Dr. Julie Philly. She's our executive vice president for health affairs. And of course, the nursing school comes up on her, of course, the medical school comes up on her side, but also the nursing school, the pharmacy school, our School of Health Professions, our public health activities, our hospitals and clinics. We've consolidated a lot of that and structured a lot of that within her office, such that the various colleges and schools and their clinical activities, they can focus on those more and rely on the common infrastructure to be supportive in helping them deal with the whole plethora of regulatory requirements that we face.
Thank you.
Dr. Calhoun, what are some of the initiatives you've launched that will reduce health disparities in your region?
Well, my answer may be surprising, maybe not. But I think it's the fact that we took on mental health very aggressively. Now, of course, there are things about outreach to communities of color and health screenings and immunization programs and all those different things that had a focus on marginalized communities, the communities that struggle with health outcomes. But it's just been my experience that one of the most devastating things for communities, whether you're talking about communities of color or whether you're talking about rural communities, is the lack of mental health services. We know that you have diabetes, but if you team up diabetes with a mental health disorder or with an addiction, that mortality increases significantly. And then you add on an additional mental health or addiction problem, and it the mortality increases that much more. So being aggressive about solving our mental health crisis is something that, despite the fact I'm a nephrologist by training, we were very proud. I was very proud to move our institution much more into the delivery of mental health services, which had not been traditionally done. And why? It doesn't generate a ton of revenue like some other things like heart programs and those kinds of things. But expanding those mental health services is so important. So we did not have a psychiatry residency training program. We now have one, and We started, in addition to the psychiatry residency program, where we have one rural psychiatric program, starting another rural psychiatric program in another small community here in Northeast Texas. We've tried to help the state by taking some of the older unused beds in our system and creating more psychiatric beds to better serve our community. We're looking at ways of working with our federally qualified health centers, helping them provide local mental health services. We've embedded psychologists. We have a large psychology program, and we've embedded psychologists in our clinics and out in the community with community-based organizations. We've done a lot, and we've changed the approach to mental health in our community. In my opinion, we've changed it, and it's a much more aggressive approach, and I'm very proud of that.
That's awesome. And mental health, as well as other diagnoses here, has caused a challenge in terms of our capacity, bed capacity, and throughput capacity, or lack thereof of throughput. So we have a question from Dr. Deanne Pillars here at UI Health, our professor of neonatology. And post-COVID, pediatric bed capacity has reached levels in Illinois, unprecedented, and certainly with RSV recently as well. So what can health systems do? What kinds of things, can you share with us that have worked?
Have worked. This is a problem all around the country right now with RSV combined with flu and the challenges it's presented for our pediatric hospitals. We just when we did our merger with our hospitals and we brought the 10 hospitals on 4.5, almost 5 years ago, within those 10 hospitals, we really didn't have neonatal units and that sort of thing. It was just not what that health system had focused on. And we have increased the emphasis there. We believe that our new medical school will be a stimulus because of the fact that we're hiring pediatric faculty and so forth. It's going to be a stimulus for improved pediatric services across our region. But I think with regard to the current crisis, I mean, you can just look at COVID. Healthcare is very, very resilient. I remember when DRGs came along for hospitals, they said DRGs are going to kill the hospitals and we're all going to go down the tubes. And I just think the healthcare people are just so darn smart. We figure our way out of these difficulties. And when COVID came along and our hospitals were stressed to the hilt, we figured out how to do it. And we were successful. And we should be very, very proud of that, pat ourselves on the back. And so with this latest crisis, with respect to pediatric critical care and pediatric beds and so forth, I am confident that as a profession, as hospitals, we will figure that out. I remember I was doing my residency at Northwestern. Something happened. This is 40 years ago. Something happened in Chicago, and the hospitals were just crushed, and we admitted patients into the hallway. I think all of us in my generation and a little bit afterward can remember having to do stuff like that. That we weren't going to turn people away at the door. We were going to take the PACU and turn it into hospital beds. We're going to put patients in the hallway, and the doctors and nurses and health professionals are going to step up, and we're going to take care of people. And I believe that kind of spirit still very much exists among our healthcare professionals. So this crisis too, like COVID, we'll get through. We'll take care of these children from the top administrator all the way down. We will do our part, and it will cause us to now look at things a little bit more, look at the organization of our hospitals, look at the allocation of beds within our hospitals, and try to be better prepared for the future. But we will get through this. I'm very confident.
Dr. Calhoun, some of us still see some moments of in the hallways and using our PACUs for alternative sites. But I think, like you highlighted, getting through this is a lot of collaborative work and teamwork and interprofessional work. So I've got sort of two questions. One from the chat that comes from Dr. Mariscalco here at UI Health. She asks, we talk about interprofessional practice skills in our students and trainees, and it's really difficult to find real world situations where this occurs. And do you have clinical programs that you're using to address this? And then there's a follow-up question that we got from Sarah Laney, the Senior Program Director for Science Innovation at the Wilder Foundation. And she asked, this is kind of an extension beyond the clinical community, but kind of connecting the clinical community with your basic life science research community to really look at innovations in how you work. So sort of two parts to that question, the clinical aspects of multidisciplinary and then the non-clinical.
Well, first of all, let me say, when things turn dark there for a little while, we're very energy conscious here at UT Tyler, and the lighting was on a motion detector and I wasn't moving. So the lights went out, and hopefully that won't happen again. That's hard, making sure that we have all the clinical access that we need in order to train the next generation of healthcare professionals. And it is, and we've experienced this, it is hard to sometimes get hospital administrators who are driven by trying to fulfill their mission of how they feel they need to serve their community, how they need to be able to afford the capital to reinvest in the clinical enterprise and so forth, and overcoming their fear that being involved in teaching is going to be costly for them. And so I think those of us who have medical schools and operate academic medical centers have to identify and be able to explain the benefits, the positives of being involved in medical education, that it really does add to a hospital or clinic's reputation to be involved in teaching, and that being involved in teaching, having your physicians involved in teaching, will help keep them up to date and will help them do a better job of providing quality to patients and a value proposition to patients. I believe medical education can do all those things, and I'm a pretty good talker. I think we can talk people into it. All that being said, we felt that it was absolutely critical for us to have an ownership/leadership position in the clinical enterprise. And we were able to work out a deal where we share governance in our 10 hospital system. And our partner committed to being supportive of medical education, not necessarily financially in every way. We have a financial arrangement, but supportive in that their doors would be open for us to bring our young physicians and nurses into the clinical environment and exposing them to that. I say all the time that we absolutely cannot train the next generation of healthcare professionals without strong relationships with our hospitals and clinics. That's where they get the hands-on experience that is so necessary in delivering high quality healthcare. And so if you have an opportunity to identify, design those kind of win-win situations, and you can exercise the necessary influence over your health system to keep them cooperative, get them to be cooperative with medical education, then I think that goes a long way to helping us identify the clinical sites that are necessary for us to accomplish our mission.
Great. Thank you so much, Dr. Calhoun. We're getting close to the top of the hour, and I've learned a lot, and just your approach. This idea of consensus building, to keep your eye on the ball about what's our mission, and the need to make forward progress despite all of the challenges that we've had our way and others that will come, I think are inspiring. And we thank you for your leadership as you left Chicago's training grounds to then do some good in East Texas. I think we have much to learn from leaders like you. So thank you for your service. So with that, I'm going to take the prerogative to present you a plaque. I believe we mailed you a plaque, and so I'm now hoping that did it arrive, Dr. Calhoun? Is that?
It arrived, and it was a surprise, and I am so honored to have that gift. Yeah, there I am.
Okay, fantastic. So we hope that you know that you've really helped us learn, and I think there's a few more sessions you'll be joining. But I think for the audience here, wanted to show that we value your time, and that we wanted to make sure that this plaque remains somewhere visible in your office, hopefully to remind yourself of the day we just had today. And that we thank you on behalf of UI Health and Dr. Barish to give us some of your time today. With that, I will also want to thank all of our attendees. We had folks join us from across multiple academic health systems in Chicago, along with the foundations and others, both in Chicago and elsewhere, including Rockford and Peoria and so forth. We're looking forward to continue our conversation in a small group session on rural health and partnerships. But with that, I'm gonna maybe thank you for your time, and thank our panelists, as well as Eileen Baker and her staff, who put together an outstanding session of Distinguished Scholar Series today. And with that, thank you, everyone. Have a good and safe and productive day. Take care, everyone. Bye-bye.